everybody, welcome back to Pre-Hospital Paradigm Podcast. I'm Scott Wildenheim. We got most of our regular crew here today. We got Ray Pace off to my left here. I got Dr. John Hale across. And our very special guest today is Derek Frost, our second Frost on the podcast series, who is the pharmacist from Portage and somehow caught the short end, pulled the short straw, and is one of our system EMS pharmacists. So, hey, welcome. Appreciate you coming on, man.
Yeah,
we've got there's honestly this whole episode kind of evolved out of a discussion with one of our providers had made an honest med error, and we'll talk about kind of how that played out. And it's like, oh wow, there's a bunch of pharmacy operational things that I take for granted, from an administrative standpoint. Certainly, we all do, because, we're involved in all of these conversations and what the system's doing and what the state is doing and what the feds are doing, the DEA is doing in some cases. We kind of take these things for granted, but, once we started talking to some of our rank and file, we realized, a lot of this information's not out there. So having said that, do we want to start with? Let's just start with medication errors, which is, I think, a big fear for a lot of providers. I mean, I can certainly think of some errors I've made in the past, and not that I ever got okay with it, but it was the impetus for me to get better. Right? It was I learned from everything as I. As I stripped it apart and got to root cause and how did I get to making that decision. So, let's kind of start with that. What's the process, both from a medical control and a pharmacy perspective, if a medication error is made?
Right. So from the pharmacy side, actually, let me start first. I'm going to not be offended that I was the second Frost on this podcast. I'm going to let that go.
We had the better looking Frost on first, yeah.
Yeah. Okay,
we'll let that fly.
Yeah. With med errors, obviously the number one thing is we want to identify it, right? And this is where it becomes really difficult, because there's such a stigma, a fear that I made an error, I'm going to get in trouble. Yep. And you're watching, your career potentially go down the drain and all the hard work and all of this, let alone whatever is going on with the patient.
Correct.
And fortunately, most med errors do not result in patient harm, but we know that some of them do.
Some periodically do, right?
So the biggest thing is recognizing that it happened, and then, handing off, hey, this med error happened. I meant to do this, but here's what it is, and now here's the situation that the patient's in. There's a time later where we talk about how did that happen, what can we do to make it better, and I'm sure we'll dive into that throughout. But that initial is just like, what's going on with the patient? How do we fix that?
And then that subsequent notification to wherever, in our case, the EMS case, we're delivering somewhere, right?
Yeah. Sure.
Is then, to stand up and say, hey, this error was made.
So if you make a med error, you're going to make multiple reports of this med error. You're going to recognize you did it, and the people you hand that patient off to, the nurses, the docs, whomever, you say, hey, I made a med error. This is the med error I made. Yep. You're going to document that med error in your documentation, and then you're also going to call whoever your officer in charge is, or whatever your process you have for reporting those med errors. You're going to make that phone call. Then you may or may not want to actually call your medical director.
Right.
The best phone call I could get, and I've gotten them before, is I've made an error. This is what my error is. What do I need to do next?
Absolutely.
You did the right thing already. You called and you reported it. Yeah. Is the patient okay? Okay, patient's okay. We can deal with the med error. Yeah. If the patient's not okay, we can talk about what we needed to do to help rescue that patient, because we do have rescues for these errors we make. We all make errors. Right. I've made errors. Everyone at this table has made a mistake in their life. We know that that's going to happen. And we actively are now working on processes now where we talk about drawing up medications and understanding the concentration of medication in a specific volume,
Yep.
and what does that equal in milligrams when we're talking about our protocol, and things that we're working on, a new app we're working on to be able to
safeguard
and
put
fix
some guardrails, and absolutely.
Exactly. So we know what's going to happen. We've accepted that there's a risk, but we understand that the benefit to our patients is worth that risk. But we have to also be conscious of the fact if we do make that mistake, recognize it, acknowledge it, share that mistake with everyone, so we can just take care of the patient.
A very long time ago, when I went to paramedic school and was my mentor at the time, did a ton of ride time with him. Honestly shaped a lot of who I am as a provider. But one of the things that we were talking about was exactly that, is medication error. Something that stuck with me, right, was he's like, if you make a medication error, basically do BLS only to fix it. Don't start adding more meds until you've talked to somebody. You're already in a mindset of having made a med error. Now you don't want to compound the problem unnecessarily. I imagine if it was something like unintentional narcotic. Actually, it's a perfect example. I had that's not my case, but it was one of my provider's case. They gave a guy 75 mics of fentanyl, which, and he was, that was still well under 1 mic per kilo. And there was other stuff on board nobody knew about. Or that was is what we ultimately suspected. It was, there's more to the story we didn't know about it. And the guy stopped breathing, right?
Yep.
And in that case, that's cut and dry. I mean, we've dealt with so many narcotic overdoses. He eventually did the right thing, started bagging the patient. Like you said, it took when we deconflicted and we went through that whole thing. He was just like, it took me too long to get to Narcan. It's like, no. The thing you needed to do was done immediately, and that was squeeze the BVM in that particular case, right? But that kind of goes back to just do the BLS stuff. Don't start stacking stuff on until you're absolutely sure that that's the right course of action.
Yeah, that's great advice. I will share a med error that I did. I did it with your wife. I was new to the department, and I had a trauma come in. I had a pulseless extremity, and I said, we'll just give her a little bit of propofol. We'll put it back in. It'll be fine. It'll be quick on, quick off. And I went up a larger dose. Not that it was an appropriate dose. I did 1 milligram per kilo for the patient, appropriate induction dose. She stopped breathing. Bags up. It's fine. We put it back in place. Everything's okay. She comes afterwards. Yeah, I took 4 milligrams of Xanax before I came in. Didn't know that when she presented.
Exactly.
And that's the reason why she stopped breathing, is we had Xannies on board plus propofol.
Yeah.
I should have done half the dose. My mistake. Guess what I don't do anymore? Whole milligram up front. And I knew better, right?
Yeah. I mean, again, two pieces to that, of course, is when we're dealing with sedatives or analgesics, you can often walk these things up, right? Now, sometimes time.
You can always give more.
You can always give more, right?
Yep.
We don't have to swing for the fences, especially in situations where we don't know. And the other part of that, obviously, is the history, right?
Yep.
Probably ask an ambiguous question, and I'm certainly guilty of it, right? Take any medications, right? And
Yep.
What was I specific about? Did you take anything today before I'd give you this stuff? Did you really zero in on it? And no, sometimes we just get broad brushstroke. That's satisfactory. Move on. I know. Here's what I want to do.
Do you have any allergies? Here's the med.
Do you have
any allergies? Here's the med. Yeah, it happens.
Wait, and recognize that the patient isn't in their normal state of health. Probably isn't in their normal state of mind. It's scary. When anytime that you all are interacting with these patients, there's a level of fear. Where did you take anything? Maybe it was something earlier that not in relation to their current event too. They may forget, may slip their mind until you start asking the more specific questions of like, oh yeah, I did take that earlier.
Or they don't want to admit it in front
Exactly.
of
Whoever.
whether that's law enforcement, whether that's family, that's.
Or it's not their med. Maybe it's not prescribed to them. The medication they took is not prescribed to them, so they don't want to admit to it because it's not theirs. And they're thinking one of us is going to look at our magic computer and know that you took Grandma Xanax or something. You know what I mean? So,
or they don't want to know that I just drank a 6-pack. My family knows I just came home drunk.
Yeah.
I'm not supposed to be drinking, and
Sure.
I give them medication, and they're already depressed because the alcohol's on board.
Yeah. What strategies can we adopt to, I mean, obviously hammering in and being a little more focused on specifically medication history if we are planning on administering something outside of the obvious ACLS resuscitation medications that are indicated regardless, right? But what kind of strategies can we help take on to make sure that we're getting patients the correct medications and in the right situation? So you talked a little bit about this app that's coming, but I think that bakes a little bit into it's all written down for you, right?
Yep.
It's all written down for you. If you're unsure, it never hurts to double check, right? I mean, it's written down. Then like the whole underpinning of this entire series is, if you're unsure, wouldn't it be awesome if we could just phone a friend and cross check that with a doctor, right? And that's the basis of the whole EMS system, right?
Yep.
Is phone a friend. I mean, there's and I guess in that same thought process is you're allowed to be smarter than protocol. I know we've said this before
Sure.
on this series. Is I certainly know many uses for meds in here that aren't written down, right? That does not prohibit me from doing it. I just have to do it with consultation with a doc, right?
Yep.
And I think I've told this story before, but before we had racemic epi in the box long ago, I had a stridorous patient. It was a stridorous tracheal cancer patient. Absolutely no, I've talked about this before. This is
The worst patients we could all have.
it was an all around scary patient, right? Who ultimately went to the OR and got a trach. I mean, it was a super sick patient, and it was just like, if I do nothing, the albuterol's not going to work. I know that. If I do nothing, I'm cutting a neck, or at that time we had a quick trach, which may or may not work, depending on how much tumor burden and whatnot's.
We just had a case like that in Portage,
right.
where we cut a neck and there was a mass there no one knew about, not even
Yeah,
patients.
right.
Yeah, bleeding complications, other things.
So
come
I'm
out of that
already
too,
just like, I'm between a rock and a hard place. The only, the best thing to do is keep him breathing. But we didn't have the racemic epi at that point. And I called our med control doc and be like, look, I need to go off script here. What do you think about me dumping a bunch of regular epi in a nebulizer? He's like, absolutely do it. And I'd like to think that consultation with that doc got that patient to the OR to have the ultimate therapy that they needed, which was a trach placed.
Yeah.
But that was just an example of you go off script, phone a friend. We've got options.
You also have a partner too, right? So in the EMS setting, if you're let's say you're a double medic unit, and you have the luxury of that, verify it with your partner, look at it with your partner, or if you want to double check the protocol book, I still think you have someone else there, right? It's no different than that. Or even another good practice too is, like, even if I draw the med, I'm probably going to hand you the syringe and the vial, right? So to me, that tells me, like, you want 4 Zofran? All right, here's the syringe with 4 Zofran. Here's the vial. And you're like, yeah, it's Zofran, cool. And then one of us probably asked, do you have allergies? Do you have allergies? Or that it's repetitive questioning. I look at that as like a double check to that point. But you have a partner as well, too.
What about some of that cross-checking kind of stuff that is best practice in your world?
Yeah, and that's the first, we're talking about, the errors that we've made. The first 2 that I made was covering a night shift call off.
I wasn't even supposed to be here,
right?
man.
I was at work a few hours ago. Now I'm
back,
here.
yeah.
It's 3:00 in the morning. Where I was at, there was no pharmacy tech overnight, so it's just me verifying the orders, filling the orders, sending it, and haven't slept in a while, and so there was nobody to do that cross check, which is built into our hospital pharmacy system, where pharmacist verifies the order, tech fills it, pharmacist verifies the right product. You skip that. when there's nobody else. And so, and came back and, hey, this is the wrong thing. Fortunately, nursing caught it. So in that case, they were my cross check. But you have somebody else with you, even if they aren't maybe your same level of training. To some extent, it's just a second set of eyes, making sure that I grabbed on Danzatron and not oxytocin, right?
Sure.
And
yeah, good
you know,
point.
'cause those are easy to make.
no, I've got a story to tail on with that.
I've got a story for that.
Yeah.
We had a training, paramedic student grabbed medication out of a bag, thought they were giving Zofran. It was epinephrine. They gave 1 milligram of IV epinephrine.
Oh my. Oh my.
Because no one verified, right? Instead of just saying, hey, I want to give Zofran, here's my syringe, here's my vial, verify. And in this case, I think that those 2 vials were stored in compartments next to each other, and they're a student, so they're not that familiar with
right.
how the drugs are stored, and they went into the wrong container, grabbed it out,
Yep.
didn't verify themselves. No one else would verify it was the right medication.
Yep.
Slight run of VTAC.
Yeah, my story's not nearly that heavy, but I was giving Dilaudid to somebody, and again, an EMT partner, right? So they don't know the pharmacokinetics, pharmacodynamics, the ins and outs of these drugs. I'm just using that person to read back to me, and at least if stuff goes wrong, they can swear that no, that's what Scott gave them. I watched him do that. He he had me. So I handed it to my partner. I said, I'm giving this, just read this back to me. And they misread hydromorphone as hydromorphine because people do that all the time. And my patient, who I had asked 3 times, 3 different ways, do they have any allergies to medications? I ask, sits up on the cot and goes, I can't have morphine. So, now I'm like, now I got to figure out, is this a drug class problem or is this an agent problem? Right? As it turned out, it was just the morphine and the histamines and all the stuff that goes along. We don't want to dive on the specifics of the drugs today because we've burned all of that.
I don't know. You got 4 drug nerds.
Right. But then it was just okay. Have you ever had Dilaudid before? Oh, I've had that because the only drug that works, of course. And
100%.
then it was okay.
But Benadryl helps too.
But still, it was that process of that me handing it to them reading it back
Sure.
aloud. Even though I had tried to put all the guardrails I could on that situation, there was still a little weave, and the patient's like, "Oh, I can't have morphine," right? Or didn't want morphine. It doesn't matter, but it stopped. It made us double check, and simple processes like that do actually work, right?
Yeah, because we're all trained the same way, right? So if it's an EMT, an advanced paramedic, a physician, a pharmacist, we're still doing, is this the right drug? Is this the right route? Is this the right dose? They might not know the specifics of it,
Correct.
but that's probably where you're going to catch a lot of errors is when they said that, it's like, oh, okay, red flag here. What's up? That it might catch that problem. It doesn't necessarily mean they're the same level. I like your point on that, but at least maybe even just saying it out loud or hearing it back, you're like, nope, that's off, or you'll catch something that's wrong.
It's different when somebody else says it to you, right?
Yes.
The cognitive processing is completely different when somebody else is saying.
It is. I would even say it's different when I had this happen to me during training, and even now when I'm attending, I'm asking my partner, hey, I just want to run something by you. And I take a problem and condense it into like a sentence.
Yeah.
I go, yeah, I don't need your help anymore.
I got it. Right.
So even just doing that, like even repeating it, saying it out loud, or condensing to something simple, if you're questioning yourself, it might give you a different way of looking at it and be like, I figured it
At
out.
my last shop, we carried albuterol and atropine separately, ipratropium separately. If I haven't 30 times in my career been like, I'm giving these, and then my partner's like, you're giving 2 atrovents? Yeah. No, I'm giving these, right? It's easy to do, especially with something, especially those bullets that are embossed. They can be hard. They can be hard
Sure.
to read. If at the time we were buying the ones that didn't have the A or the I or the A on the top.
Yeah, where you break it off, yeah.
It was just the embossing on the side, and it got. My eyes aren't great, right? And I may not have my glasses on. Like I'll take my Sharpie and run it on the embossing just so I can read it and make sure I'm giving the right thing. Now, not particularly harmful medications if I mess it up, but still, we're trying to do the right thing for the patient, and
It's still an error, right?
It's still an error.
We still want to reduce our number of errors as much as possible. and make changes to either our protocol or how we package the drugs up, whether that's in a bag that's colored or separate from a bag or underneath or on top. That's how all the little steps we go in to help make this as safe as we possibly can, because there are still millions of med errors across the country.
Let's talk about some.
Yeah. Oh no. Do you want to talk about how it's set
I was
up?
going to say, let's talk about some of the things that you have to think through when you're building these boxes, as far as where things are placed, and size of the containers, and look-alike, sound-alike stuff.
Sure.
And all that.
Yeah, and so with these boxes, it's a little bit of a game of Tetris, right? So size becomes the biggest thing. It's what actually physically fits where. And then also thinking about what drugs are going to be used together, right? So thinking about the protocol and trying to kind of put some of the drugs that are going to be used for the same indication together when possible. Not always possible, but when we can. But especially, that the top row, that's smaller containers, smaller drugs, making sure that colors. And then this was one I brought up on Danzatron oxytocin, because I remember this was one that we dealt with, and I believe we submitted to the ISMP, Institute of Safe Medication Practices, that one of them changed the coloring they had and went from being a red top to a green top. And so the Zofran and the oxytocin are both small vials with green tops, and at the time we had them right next to each other. And either we had a near miss or it actually happened. I can't remember, but we gave the wrong one.
That
happened.
I think I know of two cases where exactly that happened.
It did happen,
and it was the green. It was the Hospira green cap Zofran. It's exactly.
They're right. If you just set them down and you couldn't
tell.
If you were just going on site, let alone no, you can tell it all. And that's what. Back to Derek's point, the top's busy, right?
Yeah.
The top of the drug box is busy. We have more little cubbies, if you will. And the theory behind that, which we worked with pharmacy on, was the drugs are either going to go together or we're going to try to make polar opposite, right? But then it becomes a game of what fits where, to an extent. So, like Benadryl and epinephrine, 1 milligram and 1 ml of epi and Benadryl are together, like allergic reaction, right? And then now I have labetalol that's on the right side of the drug box, but I don't want low pressure right next to it, so we put low pressure on the left side with racemic epi.
Yeah.
Two completely ends of the spectrum. So the theory that we worked together on was, how do we make these so that even if you grabbed everything out of that cubby and had it in your hand, they should be opposite ends of the spectrum, like
different.
glucagon and Zyprexa, right? That should be like, okay, two completely different things.
Right.
And that's how we work together. And I think it shows what the Institute does and how great we work with our pharmacists and our partnership with them to prevent errors, when they do happen. Like, I mean, that was a great example of the oxytocin and Zofran. If you set those down, you could not tell. Like, or if you were not in a well-lit room and you just looking at them, that would be difficult.
They're meds that both start with O, oxytocin on Danzatron, both with green caps, both clear liquids, in a similar size vial. And it's 3 o'clock in the morning. You haven't slept.
And that's and I know that's something Ray would share frequently with me. From the pharmacy side, if I'm working, I've had my Dunkin' coffee, I've had my bagel. I'm in some form of well rested, or at least hopefully.
You're in a well-lit room.
Maybe I got some, Billie Jean by Michael Jackson jamming out. But I'm in my zone, and but these mistakes still happen in the hospital, and just because I guess especially when they're look-alike meds, they may have been put in the wrong place because of all the same things we're talking about. It may be a dispensing error. And so if you're used to where that is, you go pull that.
Muscle memory. Yeah,
yep,
true.
And then, you miss that it was different because of all of the, the EMS side of things, the not well-lit room. You've been awake for 5 minutes.
Yeah.
It's 3 o'clock in the morning. Super easy to make that error.
And complacency. I've done it 100 times.
True.
Yeah.
Well, I'm going to throw a curveball into that, too, not to interrupt you. I dropped it on the way in, right? That never happens in EMS. With the drug box, right? Or I dumped it over. Right? Let's say it's closed just like it is now, and I dumped it over, and then I stood it back up. Most everything stays in its compartment to an extent, but now I could have just shaken that up and that's an easy
Resorted itself.
100%, right?
Yep.
Because I mean that happens. We drop stuff. It's
Yeah.
closed. And a lot of times it just tips over, but that's enough to shift some of those drugs out of those little cubbies, and now it might be in a different cubby, or it's in the bottom, or where I'm used to, like, I know exactly where each cubby is, so if I go to that, I still should be verifying it, but it can be easily mixed up.
Mm-hmm.
And I think the other thing too with lookalike sounded like we had an issue with Zyprexa. All right, so Zyprexa ODT, and then now let's go to Zofran, or olanzapine and ondansetron. So we had these two ODT tabs that are in the same exact packaging, and we worked with Derek and we worked with Ashley at Geauga, like, how do we work through this? And that's where, we give ondansetron all the time, whereas we do not give olanzapine all the time. So how do we make this safer? And that's where it was put into a clear baggie with a bright green label that says this is Zyprexa, to even trigger a different word versus olanzapine. So if you were looking at it, to avoid an error, because we had med errors between the both of those. But that's where the partnership, I think, is key here. And it's good to blend our techniques, because no one wants a med error. And no one does one intentionally by any means, but just some of the safety measures we're able to put in place.
And I think going into, making that decision of how are we going to separate these, so the idea that we need to was pretty easy. But then the how and the thought process being, let's take the thing that's less used and make that just give it one more step to get into. So for the Zofran, which is a top 3 drug we give,
Sure.
looking at our overall data, we don't really want to impede that. But the Zyprexa, let's much less used. Let's create that just one extra step to prevent these errors without adding a lot of workflow burden.
Or even if it's out of the corner of my eye, you see you opening a baggie. What are you doing with that baggie? Oh, don't you
Give
want the
Zofran.
Zofran?
Yeah.
Yep.
Yeah, that's true.
Yeah.
It's outside the norm,
Stop.
so then it catches it,
Yep.
which is good. Yeah. Yeah, the workflow of it, all that. Kit check has helped tremendously
I guess
as well.
let's
Jumping ahead.
No, but if you're going to talk about kit check, I think we need to define that. I mean, again, our viewership isn't exclusively UH.
I feel like kit check's one of the one things we talked about in a lot of episodes, whether that's the drugs episodes or documentation episode. I think kit check comes up a lot, but it's a great tool that we have.
Yeah, no, it's fantastic, and there are other tools like it made by other companies that use similar and different technology. So all of it's great, but defining kit check. So you have an extra label on the medication that has an RFID chip in it, and we were able to take the whole box. The box itself has a chip in it, and put it in what looks like a big microwave oven, or it's toaster oven more so, and it will do a quick scan. Those tags get associated to medication, so we have the NDC, the lot number, the expiration date, soon to be the serial number, are all collected from that, and including where it came from. So if this Portage box ends up at Geauga or Ahuja, they're going to throw it in their kit check, and it's going to say, hey, this isn't your box.
Right.
Get this back, get this out of here. So that has cut down tremendously on our dispensing errors, because we're much less likely to forget to switch out a med or to put the wrong one in there, because the pharmacy's dealing with a lot of the same drugs look alike, and we may miss it, or we may have missed that there when the needles was used. That being said, also recognizing the limitations of the technology.
You got to it before.
Yeah, and I would say the one dispensing error that we are still, I'll say, prone to, is a medication, a vial that was used and replaced back in the box, which is why I know our education is very strong of do not do that. Because if from a pharmacy side, I have a vial in the box, the kit check's telling me everything's good.
Yep.
I have to recognize that that's empty and that cap is flipped
missing.
off. And that we do catch them, but that's the one that, like, if an error gets out, that's probably it.
Yeah. And the other thing, too, that kit check does that we've had to deal with before at Portage is the nice part about putting all of this into our system is, let's say now a drug is recalled, right? And it KitCheck automatically would email, it used to be me, Derek, Scott, and it was like, box 307 is currently at insert your fire department name here, and amiodarone has been recalled. And we dealt with a couple recalls, not a ton, but we dealt with a couple recalls, and it was so easy to literally email the pharmacist and be like, can you just run your KitCheck report for where these amio boxes are? And literally we just went down a list and called.
Right.
It was like, hey, I know you don't know me,
hey guys,
but you're at
what are you doing
whatever
today?
fire department you're at.
Now you're going to the pharmacy.
Yeah, I need you to take this box if you have it in your possession. Oh yeah, we have that. Okay, I need you to go to your pharmacy, pharmacy, and then exchange it.
Due to reasons, just do the following.
Yeah, but it's like it catches that, and it's just I don't know, definitely a good safety measure built into that.
Yeah, for sure. Additionally, we had ketamine, like 3/4 of our ketamine was going to all expire on the same day. It's like we're going to get slammed on the 30th. So we were able to put out to the squads. We knew exactly where those boxes were. Hey, you have ketamine expiring. Let's try to stage this out a little bit to not crush the pharmacy.
I need you to come this week.
Right.
I need you guys to come this week, and I need you guys to come this week.
Yeah.
And it helps with workflow. Yeah, that's perfect.
Of course, yeah. You mentioned the IMSP. I think I got those.
ISMP.
ISMP.
Yes.
Yes. Close. Tell us a little bit about what your involvement, what the greater pharmaceutical or the pharmacy overview and what they do, and then some of their other initiatives that have translated into our protocols, into what we see on our vials and stuff like that.
Yeah, so the ISMP is an organization that is focused on medication safety. And I don't want to pigeonhole them. That's my interaction with them the most. I'm sure they have more
other things
than just that. But they do a really great job of helping to get rid of that med safety stigma that we don't want to report. And so it's a place that you can go and say, hey, we had this actually happen. We had this near miss. We had this what looks to be like a potentially dangerous situation. And then they can get that out to most, I would imagine most hospitals at this point interact in some way with the ISMP, but they can send it out on their distribution lists. And they will put out these safety alerts. They also put out a quarterly action plan, and then the hospitals can, or whoever can work with those. And some of the things have not changed. I've been in pharmacy for about 10 years, and some of them, as a student, I was working on the exact same things that we're doing now. But tall man lettering is a big one that they put out.
That was my note.
Yep. So tall man lettering was a big one. So capitalizing the part of a drug name that is similar to another one. So you take prednisone, prednisolone. The LON is going to be the NISONE, the LI. Trying to spell on the fly, but you get the point.
The letters and stuff.
Yeah. I do numbers. But those are that's a really nice thing that ISMP puts out. They also will put out some things with some high alerts, medications that are more dangerous than others, especially if used inappropriately and incorrectly. So ISMP is a fantastic resource. I believe it's free. Don't quote me on that, but I'm pretty sure it's free to connect to. But I know, as I teach, pharmacy students, pharmacy residents, that's a big one we go back to.
Sure, and all of those, like that tall man lettering, we've adopted all that as part of our protocol as well, right? Because not only is it going to look like that coming out of the box on the label and stuff, but it needs to be reflected in what you're doing. And also, we've got enough of a system. We've also tied that into what our charting looks like, right? So what you're reading here and what you're seeing as far as your pick lists on your electronic charting, it all lines up, and obviously lines up with the hospital side of things too, right? So that relationship is the super important thing. I mean, this can't just be a bunch of stuff thrown into it can be. Right. But it's just going to lead to errors, right?
Correct.
So this multidisciplinary team of people coming together to engineer things for safety is ultimately what it's all about.
Yep. Lookalike sound alikes the other thing they put out. I was trying to think what I was like, there's another one. Lookalike sound alike is another one they put out, just to really bring your attention. And maybe you don't remember what the other drug is that it looks like or sounds like, but at least start to get those red flags of, hey, this is a medication that is a little bit more likely to cause an error. I should really take an extra look. To just raise up that red flag a bit.
So right now in Ohio, the scope of practice, or the ability to modify the scope of practice for EMTs has changed a little bit and allow EMTs to give IM epinephrine rather than an auto-injector only, which kind of came off the heels of a nice system-wide initiative of getting rid of ampules and going to vials. Even things like that, getting rid of glass ampules, or I know another one big, near and dear to my heart is getting D50 ampules or pre-filled out of the box. I mean, I can't tell you in my career how many crushed D50s, have splattered around the back of our drug box and the back of my ambulance, right? And it's much harder, not impossible, to break a bag of D10. So,
but getting ampules out and not requiring filter straws, right? That's another safety step too, right? You're not injecting glass shards into somebody's arm. Yeah,
correct.
And filter straws versus filter needles is another. So when you do, because drug shortages make it sometimes that we don't have a choice, right?
Yeah.
And
I think that's something also to talk about is how we try to standardize on a single concentration in that box and try not to deviate from that to help prevent med errors as well. So that way, if we standardize on, I'll pick ketamine, 100 per ml, we're not going to swap that out unless we're going to well communicate that this is a different concentration from what you're used to, so help alleviate that 3 a.m. mistake.
Right. Yeah, and we will never put two of the same vial or of the same drug into the drug box with two different concentrations.
Yes.
So, like ketamine, for example, I remember when we first introduced that, we talked about, no, we do not want two different concentrations of ketamine, because then we're just opening the door for an error.
Yes.
So we really avoid that well in working with pharmacy.
I think you were starting going down the path of shortages forcing the hand on things.
And there are times when the shortage situation, I'm knock on wood here, is better than it was, especially during the height of COVID times
absolutely.
and the supply chain issues there. But we still are making decisions on the hospital side of, we don't really love this formulation, but right now it's the only thing we can get, and we'd rather have that than nothing. And recognizing the controlled environment of the hospital versus the a little more chaotic environment of EMS, we're going to make EMS changes last when it comes to the less desirable formulations. But it can still happen, and it would be that amps are the absolute only thing we have, especially glass ampules, before we put those in. And one, I go a little off on a tangent here for a second, but I, as a pharmacist, struggle with the calling. An ampule is not a dosage. An ampule is a vessel. So when we say give an amp of, bicarb, give an amp of, whatever, I've seen a number of med errors with different sizes because there may be more options than what we have here.
Yeah, sure.
This happened with Narcan in our crash carts in the hospital. We have two different sizes of Narcan, and depending on the provider running, the rapid response, the code, whatever it may be, they say, I want Narcan, or what. We've given the wrong one both ways.
Sure.
Too much and not enough.
But
based on the intended dose. So clarifying it when we can, milligrams, mLs, but the actual measurement, because that may not be standardized based on what you're used to.
An amp is a lot easier than saying 50 milliequivalents of sodium
Of
bicarb.
sodium
So,
bicarb, right?
Absolutely. And
amp of D50 is easier than saying
Yeah.
how many grams
Yeah,
do I
but
want.
you know, I understand his point. That's
he's right.
That's ambiguous.
Oh, yeah.
I know it
yeah,
is.
That's true.
But
That's
you-
how we get pigeonholed.
you also run into the risk of you have people that for their entire careers it's been an amp of sodium bicarb, and if all of a sudden you say 50 milliequivalents, they're going to stare at you and go, what do you want?
They're turning the box upside down. Like,
Yeah.
where did he get that? No, I'm just kidding.
What are these words?
So it's a challenge both ways.